Good evening, friends. So today's topic you may call a dry topic because there is nothing clinical. But a lot of newer surgeries are getting to be available to our customers. And if your customer has full faith in you, he or she will want your opinion whether they should do, they should not do, because most of them are expensive. And consultant will always say, do this. But what are the limitations? What are the problems? You should be able to tell them. So that is why today's talk on update on newer surgeries available. Let's start the first one. Uterine artery embolization and HIFU. High intensity focused ultrasound, not the ultrasound that we do testing, but as in ultrasonic that we give for tennis elbow, etc. What is this used for? Used for fibroids. Till now, the traditional treatment was hysterectomy, which was the permanent and final solution for all fibroids present now, small, medium, big, or even seedlings present. If a patient did not want to lose the uterus, they wanted to plan a pregnancy, then they would go for abdominal or laparoscopic myomectomy. Multiple fibroids could undergo this, especially the ones which are going to obstruct the fertility. Newer treatments are, if the patient does not want even a laparoscopic scar, then there are hysteroscopic myomectomy. If the fibroid is within the endometrial cavity, then through hysteroscope pass through cervix, the surgeon will remove this fibroid. Then there is a procedure called endometrial ablation, which works both for hypertrophied endometrium, excessive menorrhagia, or a fibroid which is looking in the cavity and is bleeding heavily. Here, an electric current is used to destroy the lining of the uterus, stopping periods permanently. The same endometrial ablation, which is done through heat, is also done through radio frequency waves, and the effect is the same. MR guided, magnetic resonance guided, high intensity focused ultrasound. It spares the uterus. Yes, Dr. Aarti Mehta, many of these things are old, but then they are still comparatively newer. And why I decided to cover is that when I spoke to a cross-section of family doctors, they were not aware of it. Then uterine artery embolization, we know nowadays, embolization we know is a pathological process that the clot starts from periphery and goes to the center and causes a problem. Here we do therapeutic embolization. Embolic agents are injected into the particular branch of uterine artery that is supplying the fibroid, cutting off blood flow, causing them to shrink and die. Then we have laparoscopic or robotic myomectomy. In this only fibroids are removed, leaving the uterus in place. Uterine artery embolization, as I said, it is the procedure to shrink, because when you cut the blood supply, then the distal tissue shrinks. A chemical called polyvinyl alcohol looks like very tiny particles of sand, is injected by an interventional radiologist into the artery that is supplying the fibroid. The particles stick to the vessel wall, making a clot that blocks the blood supply. Once the blood supply is gone, the fibroid will shrink over 2 to 4 months' time. This is a picture showing the image. A catheter is introduced into the groin and taken to the branch of uterine artery supplying the fibroid. To surface, it appears very simple. Our patients go through coronary angiography, they go through other arteriography, and there are not much complication. Are you not able to see the slides? No slide visible. Very funny. I am very sorry. Now visible? Okay. I am sorry for the earlier things, but this is the first picture that is coming. So as you see, like angiography or arteriography, a catheter goes in the groin and the artery is directed by interventional radiologist into the fibroid, giving an embolus, thus shrinking the fibroid. Where is it indicated? Severe anemia due to abnormal uterine bleeding due to fibroids, an enlarged uterus, where patient doesn't want to get rid of the uterus, infertility, fibroid pressure on urinary bladder causing retention of urine or increased frequency, fibroid pressure on bowel causing constipation, dyspareunia if the size is very large and it is closer to the cervix, and if the fibroid is huge and pressing on the back spine, then neuralgic pain in the back or legs, which may be caused by fibroids pressing on the nerves. Now, for all of these treatments, indications, the prime treatment is hysterectomy, but customer doesn't want. HIFU, high intensity focused ultrasound, non-invasive uterine preserving therapeutic technique that uses non-ionizing ultrasonic waves to heat or ablate fibroids. Now, where it is MR guided, they may put radiation. It's an alternative to hysterectomy. There is MR-GFUS, MR guided focus ultrasound, that causes ablation. This has a higher risk of side effects than HIFU plain. As I said again, non-invasive uterine preserving. Lap mammectomy is the gold standard, but nowadays people, once they are told no, there is an option available with no scar, no stitches, no surgery, you go home same evening, then people want to try all that. This is the machine, HIFU, and these radiation, see, whatever waves are being given, they are so strong, they are going to burn the fibroid. Now, around the fibroid, there is uterus, there are other pelvic organs, and then side effects can occur. This is MR guided. Side effects of uterine artery embolization are bleeding, injury to the artery, injury to the uterus, a major hematoma at the site of having introduced the catheter and guide wire, and side effect of HIFU and MR guided HIFU is that it can give effects of burning around the pelvic tissue. Balloon sinuplasty is another thing. Okay, one limitation of the earlier procedures is that it doesn't clear all fibroids. Seedlings remain, which can grow again. So we should tell patient, you may have to do this all over again if the patient is in an age group that hysterectomy is not an option, not a thing to be avoided. Chronic rhinosinusitis due to viruses, bacteria, pollens, anything causes chronic sinusitis, and which has a further manifestation of polyps or swollen inferior turbinates. Functional endoscopic sinus surgery, abbreviation FESS, is the most commonly done procedure. Now that is a invasive procedure, there's a surgery. So this new thing has come out. This works on the principle of angioplasty. Minimally invasive treatment for chronic rhinosinusitis. See, the maxillary sinus drainage is anti-gravity. It is through the cilia lining the maxillary sinus interior. Somehow there is a problem and this drainage does not occur, and because of sinusitis there is a blockage in the drainage duct. Look at this picture. On the right side, if you see, on the left side the duct is open, right side it is blocked, and the whole sinus is congested. So a balloon is passed at the opening, which is inflated, thus opening the duct and restoring the drainage. It can be done in all sinuses, ethmoid, maxillary, and even frontal. But it is a temporary procedure. Patient may have to do again and again. Although FESS also is a recurrent procedure. Because see, when you are doing FESS, usually 3 procedures are done. FESS, polyp removal if there are polyps, and trimming of swollen turbinates. The cause of all 3 is chronic allergy. Now, if you operate, you are not eradicating the allergy. Patient has to take long-term oral medications or inhalers. And if they don't do that, in another 5 years or so, they are ready for surgery again. I have a patient who's undergone FESS 3 times. And the reason, she forgets to put spray and take tablets. This is maybe 5-year-old deep brain stimulation. Is a minimally invasive targeted neurosurgical intervention that enables the structures deep in the brain, which are now not working properly due to degeneration, are stimulated electrically by an implanted pacemaker. It's a complex surgery. It has become the treatment of choice for Parkinson's disease, which is refractory to or complicated by drug therapy. Many Parkinson patients respond very well. You don't have to submit to DBS, but many do not respond, or they have very bad side effects. Their DBS may be considered. A device is implanted in the brain which sends signals to the areas responsible for body movements. As we know, Parkinsonism is a movement disorder, tremors, rigidity. Electrodes can be placed in the following areas: subthalamic nucleus for tremors, slowness, rigidity, dystonia, and dyskinesia. in the thalamus itself, in the globus pallidus, again for these same indications. This is the image. If you see this in the square, you can see the electrode. It is implanted inside, and there is a neurostimulator in the chest, like a pacemaker and its battery. Once the electrode is installed, the battery or the neurostimulator is installed same time, but it is activated after a few days or weeks. A few weeks after the surgery, the pulse generator is activated, and then programming is to be done. So it's not a intervention that is okay, done, patient goes home, all fine. After a few weeks, they go back again to activate the stimulator. Takes 4 to 6 months to find the optimum stimulus. So if your patient is doing even 70-80% well with Parkinson drugs, please do not recommend deep brain stimulation. Maybe either the stimulator may be kept on 24/7 by 365 or switched off at night because you don't need stimulation at that time. There are limitations. Very invasive surgical intervention and potentially very dangerous side effects, including bleeding and infection. You saw such a long metallic device that is subject to colonization by bacteria and infection. And nervous tissue may get damaged due to this stimulation, which is very common. 4 of my patients have done. 1 is fine. 3 have gone through major complications and are worse than before. And if infections occur, that is again a problem. Meningitis, encephalitis, and maybe removal of the device. This is a very interesting surgery. It's not a surgery by itself. Now, what used to happen is, whenever a patient is undergoing neurosurgery and the patient is under anesthesia, let's say a tumor is being removed. So when the surgeon is removing the tumor, there's a huge danger that if he leaves behind an abnormal tissue or if he removes a normal tissue. If the normal tissue is removed, patient will only come to know once they come out of anesthesia. By then it is too late. So there are devices which pick up the evoked potential or electrical signals from the tissues which are about to be removed. Evoked potentials are different for normal and diseased tissue. So one is electrical potential. Second problem that was faced was, suppose there is a 4 centimeter round brain tumor. Surgeon starts operating. He has an MRI 1 day prior to surgery in front of him in the operation theater, and he removes half of the tumor. Now 4 centimeter spherical, 2 centimeter gone. Suddenly there is space inside the skull and the brain is likely to move. The surgeon must have the most recent MRI to understand where is the tumor now. So patient can't be sent to MRI machines and brought back. So about 10 years ago, Max Hospital in New Delhi installed the first intraoperative MRI. Today, of course, there are a lot of centers, but all of this is going to increase the cost. So patient should go in with proper idea what is the advantage and what is the cost. I am just, whatever I spoke just now, I am just saying, monitoring the nervous system, brain, spinal cord, and nerves when they are at risk during surgery. Nerves, that means cranial nerves, not peripheral nerves. And since it's too late, then only patient comes to know. So it is to protect the iatrogenic damage to the patients. There are different modalities: evoke potentials, motor evoke potential, brainstem auditory evoke potential if you are going to operate on the auditory cortex, visual evoke potential if you are operating on visual cortex or around the optic nerve, EEG, and electromyography. One or more of these are deployed depending on what surgery is done, so that the main aim is that patient does not get any side effects after the surgery which are due to the treatment. Overall risk of intraoperative neuromonitoring is very low. Electrical safety, like when you are monitoring, you should not give shocks, but that I think is every operation theater. They're using cauteries, they are very careful, but it's a theoretical thing only. Benefit, it has reduced the chance of post-operative paralysis, hearing loss, muscle weakness, and loss of other function like vision, usually performed by a technician, supervised by a neurologist or a physiologist. Gradually, we'll see the doctor is going to have a team of allied people. Physiologists, physicists are coming in big time where it is a technical surgery. Robotic surgery is what lab surgery can do, but certain places, this is the robo and this is the operation theater. In the center is the patient. Robotic surgeon is sitting here and operating on the thing. The best indication of robotic surgery, if I have to tell my patient, they'll say it's costing me 1.5 lakh extra. And if it's a cancer surgery, especially head and neck, abdomen, pelvis, or it's a metastatic cancer, I would say beg, borrow, and steal and pay that extra money, because the advantages are many of robotic surgery. What are the advantages? Length of stay is reduced. Post-operative infections are lesser. Need of blood transfusion is much less than conventional or lab surgery. Post-operative complication after major surgery like paralytic ileus, retention of urine, sepsis, etc. are virtually nil. Patients may come home a day or two early. Stereotactic radiosurgery is again maybe 30-year-old, but I am just introducing because many of the doctors who I spoke to were not aware. So first thing is that it's not a surgery. It's radiotherapy, which is performing the role of a surgeon by killing the tiny tumor. The non-invasive, non-surgical radiation therapy, a deep-seated tumor in the brain where the surgeon cannot reach. Then radiotactic stereosurgery is advised. Small tumors, brain, neck, spine, lungs, but it is most likely used on the brain. Delivers precisely targeted radiation beams in fewer high-dose treatments. The radiation we take for cancer is covering an organ or an area. This is pinpoint. If you remember in our childhood, we used to take a magnifying glass and focus the sun rays at a point to burn the paper. This is the same principle. We are focusing high dose radiation at a pinpoint. It works by destroying the DNA of the tumor cells like the other radiation, but it is very specific to the area where it is being given. This is the only procedure where a patient has to do CT and MRI both before the procedure, and CT complements the MRI, and then the surgeon is prepared. The treatment team, there's a big team: radiation oncologist, neurosurgeon, medical radiation physicist, dosimetrist, the person who decides the dose of radiation to be given, radiation therapist, and anesthetist in children. Why you need anesthetist? Because see, if you are giving it in the brain at a very particular point which you are focusing, and there is a shift of head by even 0.0001 millimeter, you'll destroy the normal tissue and you will leave the diseased tissue behind. If you see, this is a frame which is fixed to the bed, so the patient cannot move. And this is how the radiation is given for inaccessible, inoperable brain tumors. Multiple radiation beams going in. Generally, treatment is for one tumor is up to 30 minutes. Multiple sessions may be required if there are multiple mets. So like you have a tumor in the lung, which you're taken care of by lobectomy. The only two mets are in the brain. Then both mets will be burnt by radiotactic stereosurgery. Routine follow-up MRI. There is a similar procedure called gamma knife, which also is radiation surgery. Same principle, but it is more refined. It uses up to 192 beams to focus at a particular point. Stereotactic radio biopsy. Similarly to a surgery, if there is a tumor which we are not sure is it benign or malignant, and the surgeon needs a biopsy, it can be done through the stereotactic procedure. There is frame and frameless biopsy. If the tumor is deeper in the skull, then it is with a frame. If it is superficial, then it is frameless. Special MRI or CT. I'll show you the picture that will make you understand. This is with frame. If you see, there are pins and the frame is fixed to the skull, and this is the tumor. And this is frameless. Both are biopsy devices. This is not used for surgery. Now, a new place where stereotactic is used is breast biopsy. So many times a patient has a tumor or a suspicious shadow seen on mammography, but the surgeon cannot feel it. Now, to do an FNAC or excision, the surgeon has to feel the lump and hold it. When they cannot see, it is done by stereotactic radiobiopsy. The biggest risk of stereotactic biopsy is bleeding within the tissue, brain or breast. Bleeding in the brain can cause anything from a mild headache to shifting of midline structures. Further admission and treatment. The risk of bleeding following stereotactic biopsy is 5% and death is 1%. 1% death is huge. Additional risk can include headache from biopsy site, infection and seizures, and risks of anesthesia if any given. Bronchial thermoplasty. So before I go on the slides, I'll explain severe persistent asthma. A patient who's taking nebulizer twice a day, different inhalers 2 to 4 times a day, but still patient is in persistent severe asthma. This procedure is done. Why the bronchioles go into spasm? Because of the smooth muscle contraction. Now, if I can remove part of the muscle so that the contraction isn't as bad, then I can give relief to the patient from this severe persistent asthma despite treatment. It involves delivery of controlled therapeutic radiofrequency energy. Again, radiofrequency, that means chances of side effects are high. They heat the muscles, reduce the amount of smooth muscle, and thus give relief to the patient. Although it is said uses gentle heat, but then still there is a chance of side effects. Still a new and relatively unproved therapy, although approved by US FDA, but unproved therapy. Oral steroid is taken 2 days prior to the procedure to reduce the edema, done under general anesthesia through a bronchoscope. Then catheter is inserted and there is a catheter tip which has a device that on rotation burns the muscle. Look at this bronchoscope. Catheter is gone in and positioned in the bronchiole that has to be treated. The effect lasts for about a year. So if you have a patient who's willing to spend this money, tell them to be prepared to do it once a year. And of course, the treatment does not stop. The treatment continues, only the patient is not as uncomfortable as before. Hyperbaric oxygen therapy, very old treatment, but now with more and more people getting diabetic foot, this is coming in vogue. Type of treatment used to speed up the healing. So when you have non-healing wounds, when you have gas gangrene, when you have gangrene, when you have diabetic foot, and rarely we don't get much here decompression sickness, carbon monoxide cyanide poisoning, gangrene or severe crush injuries, before they decide to amputate, they give a chance of hyperbaric oxygen therapy if available. Refractory wounds, not healing despite vacuum dressings, infection which tissues are starving for that ventilator pushes oxygen into the lungs under pressure. Here, the rest of the body is exposed to this pure oxygen in 1.5 to 3 times the atmospheric pressure. Now understand, the air we breathe has 20% oxygen. We are giving 100% oxygen with pressure. The goal is to fill the blood with excess oxygen to repair the tissues. helps wound healing by bringing oxygen-rich plasma, and we know oxygen is required for tissue repair. Then many times in certain dead tissues, when reperfusion begins, surgical or otherwise, it causes death of the tissue due to reperfusion. The tissues cannot accept fresh blood or oxygen. HBOT therapy prevents reperfusion injury, helps block the action of harmful bacteria and forms collagen tissue and new skin cells by encouraging new blood formation, angiogenesis. There are two types. One is a single chamber, one patient per chamber, and second is multiplex chamber. Procedure session lasts up to 2 hours. Most common complication after HBO2 is trauma to the middle ear. We know our drum and middle ear gets damaged by barotrauma. Somebody gives a tight slap on the ear. That rush of air in the external auditory canal can destroy the membrane. Some feel lightheaded after the session, and claustrophobia, fatigue, and headache, because our sinuses are empty spaces. If they get filled under pressure air, then they may cause headache. But these are all temporary. The benefits outweigh the risks. Several sessions are required. Normally, people are given very tight earplugs as well as eye cover because it can cause damage there also. It should not be given for people who have had a recent ear surgery, ear trauma, or chronic otitis media, or cold or fever. OCT FFR guided PCI. This is a relatively new procedure, and we have not had, at least in our webinars, we have not requested a cardiologist to talk on that. So I'm just introducing the subject to you all. Percutaneous old balloon angioplasty POBA is the oldest method of opening up a block and patient returns to work. This was even before the stents were found. Major problem was restenosis, 20 to 40% chances of restenosis. Stent placement reduced the restenosis to 10%. Now what happens is, we know this, that above 50% blocks in critical areas in dominant arteries are managed by intervention or bypass. Now, there is a big confusion in intermediate coronary lesions, which are above 40 but below 70, and they are not at a critical junction or in a dominant artery. Now, whether these blocks are causing symptoms and should they be managed by intervention or should they be left alone? So OCT is a procedure, optic coherence tomography, which is used for retina, and FFR is fractional flow reserve. So angiography gives a 2D representation of the lesion. It does not give you 3D. So it is limited in distinguishing intermediate lesion that require stenting or the ones which will go better with appropriate medical therapy. So it is when there is a patient is symptomatic and you have intermediate lesions, these procedures are used, OCT FFR guided PCI. Cross-sectional anatomic imaging obtained from histopathology specimen and intravascular ultrasound have highlighted that the routine coronary angiography has limitations. It cannot identify intermediate lesions. This is a block, there is a plaque, and there is an intermediate plaque. The guide catheter and distal sensor, it picks up what is the blood flow or how reduced is the blood flow, and to take a decision whether angioplasty should be done or not to be done. There are two methods available in cardiac cath labs to determine the physiologic significance of a coronary stenosis. These methods rely on the decrease in intra-arterial pressure or flow. When a plaque is limiting the blood flow, these methods help it identify in intermediate lesion that although the lesion may be intermediate, it is of significance and this artery needs opening up. Current time, coronary pressure wire-derived fractional flow reserve is one method. See the plaque and the wire is going, and there's a formula by which they can calculate the blood circulation. Second is optical coherence tomography, imaging modality that uses infrared to provide high definition images. The cardiologist can see images of coronary artery, allowing to access lesion characteristic and plaque morphology, and then take a decision whether PCI is indicated or medical management is indicated. Light waves are used to take cross-sectional pictures of retina when it is used for retina. OCT for coronary artery will also use light waves. So, what pictures intravascular ultrasound will give, that is sound-based, and optical OCT is an optical analog. So, it's like similar. So, in patients with angiographically intermediate coronary lesion, coronary angiography has shown that lesion is, say, 55%. Ideally, patient should not have symptoms, but patient has symptoms. Then OCT FFR guide. Based on that, the cardiologist decides that now this patient needs an opening up of the vessel. This translated into a significant reduction in administered contrast. Now, you know that most patients who are administered contrast have dysfunctional kidneys. You have to be very careful. So, with OCT FFR, dye injection is avoided. This is a link if anybody wants to read more on this. Thrombosuction is a very old procedure, but again come into vogue for soft thrombi. Soft thrombi where the plaque is not very big, but that plaque has ruptured. It has become a complicated plaque, and due to the rupture, there is platelet aggregation and there is a soft thrombus. This thrombus is to be sucked out in the management of AMI. Thrombus aspiration catheter is used to suck out the thrombus. Out of 35 patients, this is a study in whom we initially attempted to deliver a thrombosuction device through lesion. Successful delivery happened in 88.6% patient. Wherever indicated rationally, it is hugely successful. Then intravascular lithotripsy for peripheral vasculature. Lithotripsy, we all know, is a mechanism of breaking the calculi, renal calculi mainly, and then flushing them out through the ureter and bladder. This is also the same principle used in the arteries to break the plaques. What is done for renal calculi? So this is, when a patient has a lot of vascular calcium, this is done to disrupt that and pull it out. Novel therapy for treatment of vascular calcification, mineral deposit on the walls of the arteries and veins. These stick to plaques. So then IVL, intravascular lithotripsy, helps break that. The device uses a balloon to deliver sonic pressure waves that can pass through soft arterial tissue to disrupt calcified plaque. The disrupted plaque is pulled out and then it facilitates stent placement. Does hold the potential to displace rotablator, old technology, or orbital atherectomy devices that are the standard. Shock wave, lithotripsy, shock wave, they induce calcium fractures, which open up the artery, give extra lumen, and time for stent expansion. This is the diseased artery. You can see the calcium in the walls, and this is breaking down everything. Why this should be used? Effective vessel preparation strategy. Earlier, vessel preparation was a balloon dilatation and then placing stents. But when the calcium score is very high, when the arteries are very thick, you run a risk of rupture of the artery. Then intravascular lithotripsy is a better one prior to a drug-coated balloon or stenting. Calcified plaques, mainly. Growing evidence suggests that it may even be used for aneurysms, abdominal aneurysm, before the procedures of transcatheter aortic valve replacement, TAVR, and endovascular aneurysm repair, EVAR, and thoracic endovascular aortic repair, TEVAR. Thank you. I'm sorry if it has been boring, but somewhere when the patients ask you, you'll be able to answer them. Always weigh pros and cons of the procedure. What are the advantages? What are the disadvantages? Gamma knife is similar principle as stereotactic radiosurgery, only it uses more beams. Same team, same radiation, same pinpoint therapy. Sir, cost of thermoplasty, I do not know. What I will do is, I will find out cost of all of these and put it on the Telegram group. Yeah, rotablator, Dr. Aarti Mehta, is very important, but nowadays it's not used much after the lithotripsy has come in. Thank you all. Next week, I will not be taking because I am going to Singapore to meet my daughter. And week after that, I will come. So I request all of you to give me a suggestion. I want to go back to clinical topics rather than non-clinical. So give me an idea what we have not covered till now. Thank you. Have a nice day.